And I'm just reminded that this meeting is being recorded. I guess a few housekeeping things to talk about first. Please make sure that your video and your mute is off until it's time to ask questions of our presenter. Each presenter is going to have 5 minutes, for the presentation and 5 minutes to answer questions. I will let the presenters know at the 1 minute time frame. If you have any questions, please feel free to raise your hand or to unmute yourself and speak, or if you feel more comfortable putting the questions in the chat, I would be happy to read them on your behalf. If there's any questions, please let me know. Otherwise, we will proceed with the first presentation. And please let me know if you're seeing the screen well or if there's any problems. I'll be monitoring the chat, and I'd like to invite the presenters for the first poster, Social Medicine Curriculum for Family Medicine Residents, Lessons Learned.
Hi, thank you. I hope everyone can hear me, but if not, just shout at me in the chat or something. Hi everyone, my name's Alex. I'm a first-year medical student, and I'll be talking about a social medicine curriculum for family medicine residents and the lessons learned. So for a bit of an intro, I'll just talk a bit about what social medicine actually is. So it's a field of medicine that seeks to address the impact of social conditions on individual health, population health, and the practice of medicine. In recent years, there's been a push for more targeted training in health advocacy and the social determinants of health in undergraduate and postgraduate medical curricula. For example, first step in this was the 2015 edition of Health Advocate as a CanMed's role. And the driver of these things is the need to address the ongoing health disparities seen in marginalized populations who continue to experience oppression within our healthcare system. So the aim of this research was to analyze the qualitative data from a pilot study that set out to assess the feasibility of a structured social medicine stream within postgraduate family medicine training. And the goal of the social medicine stream was to empower residents to fulfill their roles as health advocates and to increase their confidence and competencies in practicing social medicine. So this study basically focused on the lessons learned about residents' attitudes and perceived competencies in practicing social medicine. So in terms of methods, I'll start off by saying the study cohort consisted of 8 participants in the social medicine stream group who actually went through the stream, and then 6 standard curriculum family medicine residents who did not participate in the stream. So all these participants were asked to participate in focus groups to discuss their experiences of social medicine thus far in their clinical training, and then the experiences of the two groups were compared and contrasted during analysis. So in analyzing the data, we used qualitative descriptive methodology, which aims to provide a comprehensive summary of participant experiences with little interpretation by the researcher. Content analysis with an inductive approach was used, whereby analysis is reflexive and interactive, and codes arise from and are shaped by the data. So in terms of what the social medicine stream actually looked like, 6 social medicine domains were chosen in order to provide a structured way of covering various areas of social medicine. And there's a green chart on the poster there if the facilitator is able to scroll down to see the bottom bit of the poster. So those are the 6 domains. And then also, in order to give participants experiences in these domains, they completed 8 horizontal electives related to social medicine domains, and also attended monthly journal clubs around those topics. So moving to findings, what we found was that in general, residents who participated in the pilot social medicine stream conveyed that social medicine is widely applicable and should be mandatory teaching, while most participants who did not participate in the stream expressed that they thought social medicine is less widely applicable and should only be taught to those interested. So let's delve a little deeper into that. In the middle of the poster, I've made a table that outlines some major themes. And there are also some speech bubbles around there. Unfortunately, I don't think I'll have time to read the quotes within the 5 minutes, but if anyone would like me to read them out at the end, I certainly will. So for the major themes, things that both groups agreed upon were that more practical experience was needed for gaining competence in social medicine. Both groups wished that more practical clinical opportunities had been integrated into their program. And both groups also agreed that encountering opportunities to use social medicine depended on location, patient population, and the preceptor or clinician they were working with. However, in the social medicine stream group specifically, participants expressed confidence in a more widespread number of the social medicine domains, but also expressed more worry about whether they were actually competent enough in social medicine. They also said that social medicine applies to all areas of medicine and that addressing a patient's social health is important in treating a patient. So it's important to know things like their social circumstances and history. And finally, many of these participants expressed that social medicine education should be mandatory for everyone. Now looking at the themes identified in the standard curriculum group, they expressed confidence over fewer domains and also that they were not interested or unsure of incorporating social medicine into their future practice. They also expressed that only certain practitioners in certain locations need to use social medicine and that a patient's health can be effectively addressed separately from social factors, and that education in social medicine should be reserved for those who are interested. So I do have some limitations listed there. Unfortunately, I don't think I'll have time to read them within the 5 minutes, but again, I know the font is small, so if anyone wants me to go over those later, I will. But in conclusion, we saw from the findings that participants who chose to participate in the social medicine stream had very different attitudes and perceptions of social medicine than those who didn't. Which brings the question up of who social medicine education should be targeted towards. Everyone, those who are interested, or those who are not interested and perhaps haven't been exposed to the topic as much. So I've written some points for discussion below. For the sake of time, I won't read them out, but now I'd be happy to answer any questions. And thanks everyone for listening. Oh, I'd also like to acknowledge my colleagues who supported me with this research, Dr. Robin Lennox and Dr. Linda Redwood Campbell. Thanks.
Thank you very much, Alexandra. We've got a few minutes for questions. If you want to ask any questions, please unmute yourself and feel free to do so, or please feel free to use the chat. So I may be able to start us off, Alexandra. Were these findings surprising to you in terms of those who were likely to sign up for the curriculum or sign up for this experience were those who would be more interested or more invested in social medicine? Once you've answered that question, I guess the question is to you, how do you see kind of the mindset being changed once implementation perhaps of a structured health advocacy and social medicine training is integrated into medical students for those who don't see the value to start with?
Mm-hmm. Yeah, I would have to say I don't think that I am very surprised just from being a medical student and going through sort of this process of trying to learn about social determinants of health within our medical curriculum. And some people just aren't interested in it, just like some people aren't interested in pediatrics necessarily or neurology, for example. But I think when it comes to trying to integrate education like this, it's perhaps a bit more important than those other areas because patients can be affected by whether clinicians are familiar with social determinants of health and social medicine or not. I think it's hard to say whether you can change someone's mindset of being interested in this or not. And I think it's maybe a bit unfair to make people change their mindset, but I think there is a bit of a need to at least help students become more familiar with these topics and maybe get a broader sense of the fact that they should be a bit more motivated to at least be familiar with these topics so that they can properly care for their patients.
Thank you very much. There's a few things coming on the chat. A comment about being a great presentation that I'll let you read on your own. It was a great presentation. A question, and I don't know that we're going to have time for you to read out the quotes, but the next question says, do you think integrating a social medicine curriculum into existing clinical rotations, for example, internal medicine, family medicine, would be beneficial?
Mm-hmm. Yeah, I don't know if I can really speak to that properly, but I definitely think, I mean, this one was in a family medicine curriculum specifically, and I think that family medicine lends itself a bit more to being able to address social factors since you're the primary point of contact. You see a wide variety of patients and things like that. But I do think it would be beneficial to, and this is just my opinion, but I think it would be beneficial to at least integrate a bit more training for maybe health professionals who aren't as interested in the topic and potentially haven't been exposed to it as much as people who are interested, family physicians who maybe pay more attention to that sort of thing during their training. Yeah.
Great, thank you very much. I think Alexandra would probably be very open to taking some more of these questions on the chat if you wanted to send it to her privately. It is time though for us to move on to the next presentation. And for this presentation, the title is Implementation and Outcomes of an Evidence-Based Mental Health Training Program for Healthcare Workers.
Hello, everyone. Thank you for the introduction. I'm Sheila Danki. I'm a second year PhD student working with Dr. Sandra Moll on the Beyond Silence project. So just a bit of a background before we proceed to what the project was. The importance of supporting the mental health needs of healthcare workers has never been more acute than we've seen in the past few months. The emotionally demanding nature of healthcare, along with heavy workloads, pressures, lack of time and resources, long shift hours, often put our workers at an increased risk for mental health problems. And these problems, including stress, anxiety, depression, can lead to reduced productivity within the healthcare organizations and may lead to increased rates of absenteeism and, or in many cases, presenteeism, where workers continue to work despite struggling. So safeguarding the mental health of healthcare workers is crucial for efficient and safe delivery of healthcare services to all Canadians. Although there could be limited access to resources and supports as a problem or a barrier to seek out for help. Hence, the objective of this study was to implement and evaluate an innovative approach to workplace mental health training for healthcare workers in small and under-resourced community-based organizations across Ontario. So Beyond Silence is a 2-day mental health training workshop that was developed with the inputs from a range of healthcare stakeholders, and the content is customized to address the needs of healthcare workers. It is unique because it incorporates peer educators as facilitators. So peer educators are healthcare workers themselves with personal experience of mental illness or recovery. This is a contact-based education strategy that is a best practice approach for reducing stigmatized beliefs. So another thing that is important for this program was to ensure engagement following the 2-day training. So participants were having access to monthly webinars and an online community of practice where they could share and access online resources. So the method that we've used in the study was a non-randomized pre-post test design using a mixed methods approach to conduct both a process and an outcome evaluation of the Beyond Silence training programs. So about 120 healthcare workers from small under-resourced organizations participated in the training and the pre and post evaluations. And this training occurred for about a period of a year from 2018 to the end of 2019. And the training participants were mostly managers and almost women. So if you can see in the pie chart here, you can see that 84% of the participants were women. The training program, the data collection included both impact and process evaluations. So mental health literacy, stigmatized beliefs, help outreach confidence and skill, which is another important thing in this program is, I'm sorry to be going back and forth, but another important thing over here, help outreach, is through the training, they're not only going to learn about ways to seek out help for themselves, but also ways that they can provide help to their co-workers who may be struggling. So we have tried to assess those through questionnaires and surveys. Process evaluation was informed by REAIM framework, which is trying to assess reach, evaluation, adoption of the program, implementation, and maintenance. So we've done a mixed model analysis to track changes over time, and we've also run regression analysis to identify predictors for our outcomes. And we found significant improvements across all impact variables over time. So if you can see in these line graphs here, you can see the improvements in the mental health knowledge over time. I know it's really small, but I can go over the numbers and the details a little bit later after the 5 minutes. Or in case you have questions, I can take them later. But we found a significant increase in mental health knowledge and help outreach behaviors. And the opportunities to engage in behaviors were higher with time. So you can see that in the bottom right graph, where there's an increase from baseline to 3 months to 6 months and at the follow-up. And you can also see that the stigma was reduced over time. In terms of the process evaluation, the program was effective in being able to reach out to small and under-resourced organizations, and the program was delivered uniformly across locations. The feedback for the program was quite positive, where workers described that they've learned tools to be able to reach out for help, and also they've learned from the power of sharing personal experience. To sum it all up, there's definitely a value in using the peer educator approach and customizing the training to address the needs of healthcare workers. And the program was particularly effective for early adopters. And the next goals are to be able to move beyond the early adopters, to be able to reach out frontline workers and male workers, and continue to build sustainability for the program. And we're also exploring new ways through mobile health approaches to be able to reach out to the non-attenders. So we've recently launched the Beyond Silence app for healthcare workers. And we're also continuing monthly webinars to maintain learning over time. And I'm not sure if I have more time left, but I can go over the content of the program, and if you guys have any other questions about the program. And I would just like to thank the funders for this project, which is the Ministry of Labour by the Government of Ontario, and our project partners, Public Services Health and Safety Association, and the project coordinator, Lisa Wolf. So if you have any questions or you want to know more details, I'm ready to take those right now.
Thank you very much, Sheila. Please let me know if you have any questions. Please feel free to unmute yourself or put in the chat, which I'm monitoring. We do have about 3 minutes for questions. Sheila, perhaps I can start us off. I had a question about, in terms of looking at the sustained change over time. What are your plans for monitoring that, and kind of what outcome measures would you be looking at for the sustained change?
So there were a couple of things that we were looking at. The first things that we looked at is mental health knowledge, health outreach behavior. So the primary outcomes for these were mental health knowledge and health outreach behaviors. So we tried to identify 13 common behaviors that people engage in while they're reaching out to their coworkers. Some of it is like, I got in touch with a colleague whom I felt was struggling, and I shared some resources with them. So I think these were certain crucial things, because although through training programs we try to provide education, the ultimate goal is to see that sort of a behavior change. So and another thing that we all know is behavior change takes time, and education alone is not enough. So that's another thing that we're trying to see if there is a sustained impact over time. So in the bottom right graph, we can see that sustained change over 6 months, and there were more opportunities to engage in these behaviors with time. So I believe immediately after the training program, although they were equipped with knowledge and tools, the opportunity to engage in those behaviors was kind of limited, but with time you can see that grow.
Thank you very much. We do have a question on the chat. It's from Sandra Westcott. It's a very interesting talk. Thanks for sharing. Absolutely. Recognizing the importance of not just the individual, but systemic and cultural factors in supporting mental health. Did you find that there was a critical threshold for the % participation at a given institution? So looking at systemic and cultural factors.
Yes, absolutely. And that is all the more important to look at, because in order to reach out to that goal of ensuring psychological health and safety at organizational level, change that is important at the systemic level is more important. We haven't really found a critical threshold for percentage of participation at a given institution. This program was hosted by the Public Services Health and Safety Association. So we had about 2 or 3 participants from each organization who participated in the trainings that happened at different lengths across Ontario. And we try to build capacity by training them and continuing the Train the Train program, which is training the peer educators. So whatever the content that they learned in this program, they went back with tools that they're able to implement at their own workplace. So in that way, we're trying to build capacity by continuing the training and ensuring that they have tasks to do once they go back to their own workplace.
Wonderful. Thank you very much. And by following the link that you have over here, we will be able to take a look at some of the tools that you've got, that you've developed.
Yes, it's called www.beyondsilence.ca. I'm able to type that down into the chat box, and if people need to access the information and resources, you will be able to see it on this website.
That would be fantastic in the interests of time. But it's a great project. Thank you very much.
Thank you.
And I'd like to invite the next presentation. This presentation, is Communication Development in Psychiatry Trainees, Developing a Competence Framework. And I'll hand it over to their presenter.
Hi, thanks so much, Dr. Basilius, and good to see you again. And thanks so much to everybody for attending, and welcome to the new HSED students. As some of you may know, I am a just recently graduated HSED student, and this is the result of my thesis work, which I'm going to be challenged to present in 5 minutes when it took me essentially 2.5 years of work. So communication development in psychiatry trainees, developing a competence framework. So as a psychiatrist, when I was sort of thinking about what I would want to do for sort of a thesis project, I mean, communication really struck me as something that's really critical and important in our discipline, and not only in psychiatry, but also for all physicians. There's a lot of data out there to show physicians who are good communicators have better patient outcomes, less complaints, all types of things. With that, and with the transition to CBME, which, as you'll see, I actually reversed those letters by accident and caught it when I was practicing after I sent it to Sam. Oops. Being able to really understand, articulate, and teach communication abilities is going to be critical to ensure competency of all residents, but in particular psychiatry residents, because of the nature of the patients that we work with. So in this study, we really wanted to look at determining sort of what those specific competencies are that define a good communicator in psychiatry, and then to stratify those competencies along this spectrum of increasing complexity from transition to discipline all the way to transition to practice. So in terms of methods, we use a constructivist grounded theory approach and use theoretical and purposive sampling. I had 14 participants across both McMaster Psychiatry residency campuses, so Hamilton and Waterloo, which composed of 9 psychiatrists, 5 psychologists, and 1 social worker, all who supervise residents on core psychiatry or psychotherapy rotations. We created a semi-structured interview guide around communication that was iteratively updated. I did the initial line-by-line coding for the first few transcripts and created a code set to improve reflexivity. Marco Zachnini, who I believe is watching this presentation as well, was my co-coder, and he co-coded 50% of the 14 transcripts that we had. We both engaged in reflexive memoing, and the research team had regular discussions during the analysis process. We actually did also have a member checking process that was completed by email. So the results sort of fell into 5 categories. So the first, there's 2 clusters. One, as you can sort of see on that left-hand part of the screen, are the communication skills that start to develop early in residency training, and then on the right hand you see the ones that are refined later in residency. So that first chunk was refining a previously established relational ability. So essentially what this came down to is that medical students develop some core communication skills in medical school, things like making eye contact and using appropriate body language and listening and empathy and things like that. And it was noted that those things were refined to a higher level during those early phases of residency training. The second theme that came through was developing this repertoire of core psychiatric communication abilities. So the participants recognized there was certain things that only psychiatrists in psychiatry training needed to develop as skills, things like de-escalation training, certain psychotherapeutic skills, specific psychiatry knowledge that contributed to their ability to communicate well with patients. A third theme that I found really interesting that came up was around managing the internal self. So this was 2 things. One was around this concept of reflection, actually being able to reflect either in the moment or after the moment as to how that interaction went, to change and update your interview style as you progress. And the other part was actually managing your own internal emotions. Sometimes we have reactions to patients, and it was understood by psychiatric educators that it was critical to be able to manage those reactions when interacting in a patient interaction. I like the quote for that one that I left below from one of our psychology participants. I use the term leaking. We were in a group with one of the most interpersonally challenging patients because he was openly hostile and dismissive, and the resident leaked how irritated she was. That gives you a sense. The final 2 abilities that develop later in residency are around developing a flexible, personalized style, where really residents are pulling in all these abilities that they begin to develop and hone in early residency to flexibly interview different types of complicated patients in different types of situations. This really dovetails with that last theme around partnering with patients to co-create treatment plans. And I think the quote really sums up sort of what we're getting at here. As you approach the end of residency, thinking about using your relationship as leverage with a client and how that changes the way that you communicate with somebody. Asking somebody for something because you both think that it's important. So in terms of discussion and next steps, you can see we have these 3 core abilities and the 2 higher level abilities that are seen as integrative and developed later in training. Interestingly enough, we did look at context dependence and didn't find any of that was identified. Instead, there was really this need to flexibly implement different skills in different scenarios that seems to be most important for psychiatric trainees. So my hope is that this contributes an initial framework for the development of psychiatric psychiatric communication abilities that can then be tested and hopefully used both for curriculum as well as assessment development. So with that, I am happy to take any questions. Thank you.
Wonderful, Natasha. Thank you very, very much. A super interesting thesis, and amazing how you kind of siphoned it down to 5 minutes. I'm going to look at the chat first, and then ask anybody who has any questions to also unmute themselves. Comment question from Tala. Thank you, Dr. Snellgrove. Do you think that themes would be different if psychiatry patients were asked what competencies they think are important from their healthcare provider, and using those themes from the patients when constructing a competence framework?
Yeah, so this is a really interesting question. I mean, it's a bit of theorizing, because obviously that's not what we did. Sort of within the limits of a master's program, would have been some sort of feasibility issues in terms of potentially getting that done in the timeline that I needed to. But interestingly enough, I was actually chatting with this about our vice chair in our department in terms of the patient perspective. And it's so incredibly valuable, and it could provide a really neat next step. What I would say is I think it's probably a bit of both, right? So I think that psychiatric patients and patients in general would expect their providers to be experts in their area. So having that repertoire of core abilities probably would be seen as important. And having those relational abilities, there is some evidence out there in the literature that patients do want providers who listen, who care, who are empathetic and genuine. So that, I think, would be things that would be the same. Patients also value, and I think this is part of sort of our culture in Canadian medicine, their treatment providers to partner with them and sort of co-create treatment plans, and being part of that co-treatment planning has really become increasingly important. So I wouldn't be surprised if that came out as a theme as well. The other two I'm not so sure about. I think it would be really fascinating to look at the patient perspective. And certainly, as I said, I think we're wanting to incorporate that more and more and more in the work that we do as educators and in medicine. So it certainly represents a very neat next step. Thank you so much for that question.
We do have a couple more minutes for questions if anybody has them.
And I appreciate the thank you for being able to do this in 5 minutes. It was certainly a challenge to distill down 2.5 years of work.
One of the questions that I had as I was listening to the presentation and reading your poster, I was struck by, there's a lot of similarities between communication development and a psychiatric trainee versus any other trainee, really, right? Anybody who deals with patients, you can have patients who are, I mean, in terms of communication skills, those transcend psychiatric patients only. And I guess my questions are, number one, how do you see this potentially being generalized to communication skill development in non-psychiatric psychiatry trainees? And what are your thoughts about kind of being explicit and actually letting residents know, or letting trainees know about these steps of development communication, and making them aware in terms of how to aspire to that managing internal self as the end step and goal?
Yeah, so in terms of the first question about this applying to other trainees, interestingly enough, and this is part I couldn't share with you just because of the 5 minutes I was given to present, I did go and look at the communication for the CanMEDS framework and actually matched up the theme that came out of this work with the CanMEDS framework. And interestingly enough, all the abilities actually did turn up there. And there are things that do seem to be broadly applicable across all disciplines. The managing internal self wasn't as reflected in CanMEDS as in other areas. So whether or not that's something that's a little bit more specific to psychiatry training based on the patients that we interact with, or whether it's just not well reflected in CanMEDS, I think is a really interesting question. I mean, certainly this type of work could be done across any discipline to see how similar or how different we might be, but certainly there are some of those themes that come through. And Ernie, I'm sorry, what was your second question? I apologize.
I think you spoke about the next steps in terms of looking at a curriculum or assessment development around your findings. And I guess one of the questions that I had was, do you feel that maybe even just explaining to trainees that this is the natural trajectory of their growth in communication development, eventually making it to that end goal of managing the internal self, would be a way of giving them the milestones that they're trying to achieve? So even if, apart from curriculum and assessment, letting somebody know that eventually we see you going from refining your relational abilities, developing a repertoire of core abilities, and eventually managing the internal self and partnering with patients as the way that we'd like you to develop would be of value.
Yes, in short. Yes. The longer answer, other than just saying yes, is that it makes no sense for there to be this hidden curriculum, essentially, of things we're expecting residents to achieve during residency. I think that's part of the hope of CBME, is that what those milestones and EPAs and skills that residents are expected to achieve are transparent to both educators and residents. So certainly sharing this, I think, would only be of benefit for residents understanding what they really do need to learn and achieve during their time in residency training.
Thank you. I don't see any questions on the chat. If anybody has a question from Natasha, we're close to running out of time. Please speak up. All right, so thank you very much, Natasha. We're gonna go to the next presentation. And this presentation is, the title is Residency Program Changes Before Competency-Based Medical Education, a survey of Canadian medical oncology program directors. And presenting today is Ruchi Arora.
Okay, thanks so much. Hi, everyone. My name's Ruchi Arora. So I am a almost PGY7 medical oncology fellow at McMaster, as well as a student in the Health Sciences Education Master's program. So today I'm going to talk to you about this project that we did, the survey of Canadian medical oncology program directors about planned changes in CBME. So as a bit of background, I mean, most of us know what CBME is, but just as a refresher, in the traditional model of medical education, competence was typically assumed after one completed the requisite time in training, and advancement in training was based more on time in training rather than on the demonstration of competence. And so CBME really de-emphasizes time-based training and instead puts the onus on learning outcomes and the demonstration of competence. And it's been broadly implemented in many Canadian medical specialties, and it's anticipated to have widespread adoption by 2022. And just a bit more about CBME. So it certainly has the potential to benefit learners who are struggling by identifying gaps early in their training, but also those who demonstrate competence sooner can be given more targeted and higher level training opportunities. And so I just presented in this chart here a formal comparison between time-based training versus CBME, but I won't go through all of those details. So how does this fit into medical oncology residency training? Well, medical oncology training involves 3 years of internal medicine, followed by 2 years of core medical oncology training. And so during all this training in medical oncology, there are 4 stages along the competence curriculum. I have a figure of that here that's been presented by the Royal College. So those 4 stages are transition to discipline, foundations of discipline, core of discipline, and transition to practice. There are things called EPAs, or entrustable professional activities, which are the essential tasks of the specialty that a trainee must demonstrate. And there are RTEs, or required training experiences, or mandatory clinical experiences that residency training programs must provide to their trainees. So the objective of our study was really to determine and measure the specific curriculum and programmatic changes that were being implemented by medical oncology program directors in the transition to CBME. So we performed a cross-sectional survey of all Canadian medical oncology program directors in May of 2018, which was 2 months prior to the official launch of CBME. The survey was developed through a literature review and expert consultation, and the questions on the survey fell into 5 broad categories. So specifically, 1, structural and curricular rotation changes; 2, orientation of incoming residents to CBME; 3, changes to learning resources for residents; 4, changes to the methods of teaching assessment for trainees; and 5, engagement of faculty members. So jumping to the results, I'll just present the high-level mean results here. We had a 93.3% response rate. So all program directors were changing at least 1 rotation, as you can see in the graph here. Most commonly, they were changing the hematology oncology rotation, and typical changes were they were moving the rotation from PGY4 to PGY5, they were removing call responsibilities from that rotation, or they were eliminating it entirely. The foundations block was being moved earlier, and blocks where residents had to have more autonomy, such as electives or longitudinal clinics, were being moved to later in training as well. And then in terms of the learning resources that were provided for residents, 79% of program directors stated that they were starting to use electronic teaching modules, but other changes they were making were changing up academic half day to fit the objectives of CBME, and many of them were also incorporating new training experiences. And so in this pie graph here, you can see a breakdown of those new training experiences, and the most common one they were implementing was the research curriculum. In terms of the methods of assessment, they were also changing. So 86% of program directors developed curriculum maps, and about 50% were switching to the Royal College e-portfolio platform, and 65% were eliminating ITERs entirely and switching instead to EPAs, and 29% were using EPAs for especially difficult to examine scenarios. So for example, management of oncologic emergencies, which does not happen necessarily every day. With respect to responsibility of faculty members, 86% of program directors reported that they were introducing academic coaches and advisors. All programs had planned for a competence committee, and the majority of them had already met, and the majority of them had 5 to 6 members. And the majority of program directors, interestingly, also reported being very concerned about the effect of workplace assessment and observations on clinic flow. So to conclude, Canadian Medical Oncology Program Directors implemented a variety of changes in preparation for the transition to CBME, including resequencing core rotations to being earlier, adding supplementary e-modules for learning, using EPAs as a primary means of evaluation, and engaging faculty through forming a competence committee, as well as having academic coaches. And overall, we feel that CBME is encouraging medical oncology program directors to reevaluate their current method of educational delivery and to better find ways to align resident training experiences with learning outcomes. And it seems that program directors need to find more innovative ways to align these clinical exposures to the required training experiences. And so as an example of that, eliminating a radiation oncology or a palliative care rotation entirely, but instead emphasizing those relevant points during a medical oncology rotation when it becomes relevant. So that's all. Thank you so much, and I'd be glad to take any questions.
Wonderful. Thank you very much. You ended right at the time that my timer went off. We do have 5 minutes for questions. If people have any questions, please feel free to use the chat or to speak directly. I do have a question from Bronte Johnson on the chat saying, amazing work, Ruchi. How do you see the results of your project expanding into other specialties?
Yeah, thanks for the question, Bronte. So many specialties have already moved to CBM, but medical oncology is one of the earliest adopters. We have identified a lot of changes that program directors have made in anticipation. I think what's going to happen is that there's going to be a follow-up survey of residents and program directors once CBME has sort of officially transitioned. And then based on what we learn from that, there will be other programs that are late adopters, but they'll actually get to learn from our experiences and our, our ups and downs. There's not a lot of follow-up right now because this has only been going on for about 1.5 years. And so there's probably some downstream effects that we're not entirely certain of. For example, moving around rotations might affect call and service requirements. And so I think some of these earlier programs that are adopting CBME may identify some of these challenges and then be able to inform future programs that are transitioning a bit later to CBME. And so hopefully that will help other programs adopt it a little bit more seamlessly.
Thank you. There's another question in the chat from Syed Osmani. Wonderful presentation. Having trained in the earlier program, what are your personal observations about CBME in oncology training?
Oh, that's a great question. So interestingly, I actually finished my core residency training just before it started, but there are the residents now in the program are going through it. So I think, you know, because it's still quite early, there definitely is, in the beginning at least, there was a lot of anxiety around how is this practically going to work, a lot of onus on the trainees to seek out mentorship and seek out faculty who are willing to do these assessments. But I think it's actually integrated relatively well. So one thing I did not get a chance to present in my presentation for time constraints was that program directors were asked, how do they plan to make this feasible? So to work around time constraints in clinic. And one of the things that was mentioned that I can attest to being done is that they mentioned maybe observing residents when they're in somebody else's clinic, or when the resident has their own longitudinal clinic, or looking at the clinic list in the beginning of the day and just proactively identifying which patients on the list would be really good for an assessment, and then just sort of dedicating that time preemptively. So I think with some of those strategies in place, it's become more feasible, but it's definitely a work in progress.
And one last question from the chat from Martha Spencer. Thanks for your presentation. Wondering what you think about how faculty development, or the lack of, affects CBME. That's a very loaded question, and I'm going to say you've got 1 minute, please.
Okay, great question. I think the bottom line is I think we need more faculty development. There's been quite a bit of work done already. I know our faculty mentors have been prepped, leading up to CBME, but there's always more information. There's always more training that can be done. And so I think probably now that this has been piloted in a few programs, we can take what's been learned from that, maybe get some of the faculty's perspectives, and use that to inform faculty development moving forward. But bottom line is I think there needs to be more faculty development so that it doesn't create so much anxiety on the trainees to get all these things done. It kind of shares the responsibility among everyone involved.
Wonderful. And maybe I'll take this opportunity to put a plug in for the CBME office at Postgrad. So it's cbmepg.mcmaster.ca, and there's a large variety of offerings that are dedicated specifically for development and faculty development in CBME, and workshops ongoing, as well as electronic modules that I would definitely encourage anybody who is pre-CBME, in CBME, post-CBME to take a look at and see. So thank you for these wonderful questions. Lots of really interesting conversations, and thank you very much, Ruchi. We're going to move on to our final presentation, and the title for this presentation is The Impact of New Surgical Coaching Tool, Facilitating Collaborative Teaching Experiences, and the presenter is Sindri Tran.
Great, thank you so much. I hope you can hear me well.
Sindri, we actually can hear you very faintly. Is there any way that you can bring your microphone up or speaker closer to you?
Is this better, or is it just the same?
It's about the same, but I think we can make it through and hear you.
Okay, hold on. Okay, how about this?
That is better, thank you.
Okay, great. All right, so as all surgical programs are transitioning to CBME, as we all know, there is a fundamental change in the role and nature of assessment and feedback from the previous time-based training. So one of the key issues is that the surgical staff have a clear purpose for their feedback, but resident perceptions don't always match their staff's intentions. And that perception then hinders the intended educational effect and prevents learner development. And there's also always challenges with new assessment tools like the CBME's formative work-based assessments, which could be rendered ineffective if poorly understood and applied. And increasingly, the feedback literature are advocating for and emphasizing the use of coaching techniques to meet the new demands of CBME. Previous work from our group found that the surgical staff and resident experiences with coaching to be vastly inconsistent and informal. And notably, the focus on learner-directed goals and consistent rapport that are identified as really important for successful learning in the coaching literature were largely absent. So working with several surgical staff and residents, our group designed this new coaching checklist to highlight these missing areas and fit in within existing surgical activities. So we achieved this through an iterative process of interviews, refinements, and feedback from the staff and residents at McMaster, and combined this data with coaching techniques, as well as 2 surgery-appropriate coaching models from the broader literature. And rather than being a very strict checklist that has to be completed every time, the objective of this tool was to provide a framework and act as a guide. So the purpose of this study was to explore the impact of this tool on teaching and learning experiences within the operating room or the OR. 3 staff and 3 surgical residents from different surgical programs used the new coaching checklist for 5 weeks. And following this, they participated in one-on-one semi-structured interviews. These interviews explored the overall experience using the coaching tool, barriers and facilitators to use of the tool, and perceived effectiveness of the tool. The transcriptions were analyzed independently by 2 researchers using inductive semantic thematic analysis. And overall, participants reported the coaching tool to be very helpful, creating a consistent, structured framework for coaching in the OR, providing more opportunities for persistent interactions and communication, facilitating more directed feedback, and setting an expectation of coaching between the staff and residents. All participants believe its use would be valuable for the CBME rollout, especially as the programs transition into the new curriculum this July. They believe the coaching tool provides a more formalized framework for conversations that will facilitate the EPA identification through the goal setting, completion of the work-based assessments through direct observation, and performance change through real-time feedback and co-development of learning goals. The staff and residents report that the tool is comprehensive and straightforward to use and would be easily adaptable to make a habit of using in the long term, especially with CBME. The staff believe that the tool is useful for all years of residency, whilst the residents believe it's most beneficial for the year they're currently in. So junior residents report that the tool is useful to learn their roles in the OR and set up a relationship with the staff. And the senior residents believe it's useful for goal orientation and more directed feedback for their future practice. All participants also note that there's a potential for cultivating more of a culture of coaching and growth with continuous use of the tool. So in conclusion, the coaching tool facilitates a more collaborative teaching and learning environment, as well as encourages bidirectional communication. The next steps will be creating a smaller printed pocket version of the tool and then potentially a phone app for more accessibility. Future work will further explore how the tool will help provision and interpretation of meaningful feedback and improving the culture around assessment in CBME. Thank you.
Thank you very much, Cindy. We do have a few minutes for questions. Maybe as we're waiting for the chat, for people to put some questions on the chat, Cindy, can you give us an idea of what was in this tool? What was on the checklist?
Yeah, so the checklist integrates something called the BID model. So it stands for briefing, interactive teaching, and debriefing. So this has 3 steps. The first step is briefing, which is assessment of learner needs and learning objectives. And then the interactive teaching, which is where the coaching would occur. This one is combined with the SWICE model, which supports 4 levels. And it depends on the resident's experience and the year that they're in. So with this SWICE model during interactive and in the OR, it's show and tell, so residents as the primary surgical assistant, smart help, which is critical staff guidance, dumb help, which is skilled staff assistance with no guidance, and then no help, where the resident is fully independent with staff supervision. And then it's there is the final step of BID, which is debriefing. And this consists of just a reflection of the learner's performance, their attainment of goals and future goals. This allows the staff to see the resident perspective and then also reflection for future learning goals.
Thank you. And that SWIFE model, I don't know if I'm familiar with it, but it sounds very much like the O score with the 4s and 5s. I had to assist. I didn't have to be there. That kind of spectrum am I interpreting that right? So briefing about the learner's needs and objectives, watching and coaching in the moment in the OR, and giving a bit of a feedback in terms of how much assistance is needing, and then giving that verbal feedback and some tips and tricks, I guess, in the debriefing section of the BID model.
Right, yeah, exactly. So this was made to be very time efficient. So like even the briefing, it would be at the scrub sink, for example, or during opening. And then of course the interactive coaching within the operation procedure with a focus on the goal that they discussed earlier. And then the final step of preoperative briefing, which would be even during closing or even a call, just a brief like reflection.
And did either the staff participants or the trainees, were they engaged in any training around coaching?
Right, so there was a small orientation with the tool, but so we were trying to make this so it's very straightforward and that they didn't need too much training. But what we might find is that we might need some sort of more of a workshop do we need to like have them more familiarized with the coaching methodology for them to engage in it? Right now, it seems like they find it very straightforward and they are using it correctly, but more future work might be needed to see if that's necessary.
Yes, fantastic. And there's a huge body of literature around coaching that I'm sure you're familiar with, and workshops through the Royal College, modules through the Royal College as well that I'm sure you're familiar with, and through the CBME office. I'm just looking at the chat. There is a question from Mary asking if there's a publication that shares the coaching tool at this point.
So that's in the works.
Great. Well, we look forward to seeing that publication and the coaching tool, and for you, expanding it as well. It sounds like there's next steps might be looking at using it with more people and testing it out. I thank you, Cindy, for presenting, and a big thank you to all our presenters today, as well as to all our participants. And the questions were fantastic and the interactivity was great. It's been a privilege facilitating this. It is now 1:16 p.m. So even though we started a few minutes late, we are able to end on time so that everyone can join the closing remarks at 1:20. So have a great day, everyone. Thank you for joining us.